Hey everyone, thanks for coming. For those online, on behalf of Scott Goldstein, welcome to the Pikesville Volunteer Fire Company Training Space. My name is Sean Barinholtz. I'm anesthesia and adult critical care at Hopkins. I'm a member here at Pikesville, and I have the pleasure of serving in the medical director's office for on behalf of the medical director's office, Dr. Sagel, representing the medical director's office, Dr. Pollack, who's not able to join us, and Dr. Wittberg as well, who's often in attendance. The EMS office, Director Schenning, who's with us tonight, Captain Willits, thanks for coming, Captain Stewart, who aren't able to be here with us today, are still, in addition to providing education to EMS, she's also involved in injury prevention efforts and quality improvement in the care of injured children at Children's National Hospital. What I've also learned about Cindy, a couple of things. So number one, for being an incredibly passionate educator, traveling over an hour and a half to be here for just tonight alone. For that. And I've also learned that you as well, like us, right? We got to start in EMS through EMS, just like I did and Jeff. Thanks for that. And then also your dedication to lifelong learning, right? So you're starting your doctoral program in nursing at Hopkins coming up, and that's really exciting. If I can support you during that, please feel free to reach out to me.
I'll let you know.
That's beautiful. Cindy, thanks for being here.
In the back. No. But I got one there. Perfect. All right, great.
Thanks.
Well, thank you guys for coming. I know it's like 7 o'clock on a Thursday. I was like, oh God, okay, but it's true. But so I started in EMS in 1999 with the Dale City Volunteer Fire Department, and it really changed my life, and it is the basis of everything that I do now. I went from being somebody who was like afraid to touch a patient and could not do a patient assessment because can you really do a full head to toe assessment if you never touch the patient? No. And I had officers and preceptors and everybody that trained me to get to where I am now, and it is literally the basis of everything that I stand on. And I miss running at the fire department. I stopped running a few years ago just because I've been taking care of my grandparents, and I couldn't like take care of the community if I had to like stuff I had to do at home. But thank you again for coming. Okay, so mechanism of injury. So that's something that we've all heard before, right? So mechanism, it's definitely a thing. It kind of gives us a guide of like what we should be looking for. But the whole crux of tonight is about assessment. So I think mechanism of injury, it is a thing, but I think assessment is a better thing. So when you're doing your assessment of any trauma patient, we always go through primary survey. So primary survey, your A, B, C, D, E, so airway, breathing, circulation. So what does D stand for? Anyone? Disability. And when we say disability, how are we assessing that in a regular patient or a pediatric patient? Are we looking at their pupils? Are we seeing, like, can they talk? Are they acting normal? Are we getting a GCS? Looking at, like, AVPU, like alert, verbal, painful, unconscious, stuff like that. And then E, what does E stand for? Exposure, perfect. So you can't see what you can't see, so exposing patients, but also remembering to, you know, keep them warm at the same time. You know, the whole thing, like if you're not sweating, your patient's not warm enough. E, like in my list of things I never wanted to run, it was like peds, any pregnant patient, and then a pregnant patient having a baby. I was like, but peds were even scarier to me than that. And like, I remember what it was like hearing the word peds, and I was like, oh my God, like and that makes sense because we spend about like completely fine or completely not fine. So when you're thinking about peds, like if you have an unconscious pediatric patient, obviously you just want to do like your head to toe assessment. But if you have a conscious pediatric patient, sometimes it's a little bit easier for you and them if you start at the toes and go to the head, because you're gaining the child's trust as you're doing that. So if you start here and they see that you're not going to do anything that's extremely painful or scary, sometimes it's easier to go from the toes to the head. But that's only in a very stable patient. So, you know, if you have a kid that fell off the monkey bars and they're acting completely appropriate, you don't want to like start going up to them and like messing with their head. You know, you want to start at their toes. Like, can you move your toes and then go up from there? And then for the secondary survey, once they get to the hospital, that's when they're doing like labs and radiology and then making a plan for definitive management. So we're just going to go basically through like head to toe and things that we're looking for in a trauma patient. So when we're looking at the head and the neck, we're looking at, remember, the whole DCAP BTLS. So, you know, deformities, contusions, abrasions, punctures, you know, all of those things. And we're looking for major facial injuries. So for neck vein distension, has anybody seen that in a real patient? Yeah, probably with like your adults, right? You're like your CHFers that have like backing up in the lungs and you're seeing like these big veins protruding. Maybe you've really pissed off your mom and like she starts yelling and then she gets it and you're like, okay, is she mad or is she having like a cardiac or lung problem? So what causes like JVD or the vein distension in a pediatric patient? What would cause something like that? Yes. A punctured lung, yep, because you have like a backup. So basically, if you see this, is this like a stable patient or an unstable patient? Unstable, so that's like rapid transport to the hospital. How about tracheal deviation? Is that anything that we ever want to see? No. Stable or unstable? Like unstable, you want to get them to the hospital. So for subcutaneous emphysema, has anybody ever felt that? So I was in EMS for 12 years and never felt it on a patient in EMS. I was a tech in an emergency room at the Washington Hospital Center next door to Children's before I started there. And that was the first time I felt it. You know, they tell you it feels like Rice Krispies under the skin. So if you like press, it kind of looks puffy and then you press down on it. It really does feel like Rice Krispies. So what is that? What are you feeling? Air. So if you're feeling air underneath the skin in a place anywhere on the body, is that a good sign or a bad sign? Bad sign. You want obviously rapid transport. Okay, so what are we seeing here? Battle signs. So what injury causes a battle sign? Basilar skull fracture. What's the one thing, like EMS doesn't do this, but in the hospital, anybody have any idea of what you can't put in a patient with a basilar skull fracture? Yeah, a nasopharyngeal tube. And do you want to put, you can put an NP airway in, but would you want to put an NP airway in a patient like this? Not at all. So you obviously want to go right to an OP. And why is that? Absolutely. So like the base of your skull, so a lot of, it can get confusing because when you're thinking about the skull, you have like your occiput right here, but the base of your skull is right there. And the base is connected to all of the sinuses and everything where they would put that NP, and the NP could easily go into the brain. We don't want to do that. That's going to cause more damage. So if you see bruising behind the ears, that's a bad sign of a basilar skull fracture. You don't want to put an NP airway in. So what's that? Oh yeah. So that's a really good question. I'm glad you brought that up. So bruising, you don't always see right off the bat. Some bruises can take up to 72 hours to appear. It just depends on where the blunt force hit. So if you have blunt force in an area that's really padded, like the abdomen, you're not gonna see a bruise right away. You most of the time aren't gonna see battle signs right away either. So if you saw battle signs on a patient, what would you think? It's been a minute. It could be a long minute. So that could also be something, especially in pediatric patients, if you're getting called for a child that fell and you look behind their ears, you see this bruising, you're like, well, when did this happen? And that can like raise your index of suspicion of, was this an accident? How did this happen? This doesn't make sense. Thank you for bringing that up. So what's this called? And there's a big hint on the top. Raccoon eyes, absolutely. What is that indicative of? Absolutely, also a basilar skull fracture right away. So if you are running a call for any type of reason and you see this, that's another time your index of suspicion has been raised. And what don't we want to put in a patient with a basilar skull fracture? NP airway. For that particular one, the basilar skull fracture is just like, I don't really know how the blood gets from the base of the skull in here, but it does.
Emblematic.
Yeah. Okay, so we're moving to the chest. So what are we looking at when we're looking at the chest? We're looking that it's moving up and down, not moving like this. So if the chest is moving like this, what does that tell us? Number one, it's bad, right? Number two, what does that tell us? Possibly a flail chest. How many ribs have to be broken in order to have a flail chest? I'm sorry? A lot, so like 3 or more in one segment. We're also looking for all of like the DCAT BTLS. So you're looking for all of the normal things as well. We're looking to see if it's stable. So when you're like going down and feeling, you want to make sure that nothing crunches when you go in. You want to make sure that you don't feel those Rice Krispies, because the Rice Krispies, that's air where it shouldn't be. And then we're also looking for like the crunchy, so crepitus. So if you're feeling like bone crunchies when you're pressing in, also not a great thing. So breath sounds, how easy are those to hear in the back of an ambulance? I'm sure everybody can hear them great, yeah. So you gotta do the best you can. And heart tones, like everybody great at like distinguishing like a gala between a murmur and S1 and S2? No. I mean, I'm terrible at it, and that's like in a like controlled environment in an ICU, and I'm like, is that a murmur? Everybody said it was a murmur, but we're not here in EMS to distinguish different types of murmur. Like, do they have a heartbeat? Is it regular? Is it irregular? You know, does it match the pulse? Is the pulse strong? Is it weak? And then the abdomen. So, yes.
I always struggle with the respirations.
Yes. Absolutely. So the trick for respiratory rates with kids, look at the belly. The belly is the best place to look, because most of the time, especially if you see a kid, they are already nervous, you're nervous, everybody's like at the 10th level of anxiety. So the belly's really good, but the only thing is most of the time you have to like lift up their little shirt, and that might make them uncomfortable. But another great place is the nose. So looking for, like if they're having respiratory distress, children will nasal flare. So if you flare your nostrils, kids just do it automatically if they are having trouble. Adults will too, but not as much as kids will. And if you just watch their nose move, you can count respirations that way. And those are my 2 tricks for kids, especially with asthma. Like they belly breathe like nobody's business. So abdomen, so we're looking for all of these things. So we're palpating. We're gonna, like, are we gonna try to listen for bowel sounds in the back of the ambulance? No. You want to know, is the belly soft? Is it hard? When you press down, is there pain? Was the pain when you pressed down or when you left off? You're looking for any signs of trauma to the belly. So the pelvis. So when we're looking at the pelvis, we want to make sure that it's stable. So when we press in from the sides, if we feel any type of crunching, do we do anything else? No, we don't want to press down after that. And we definitely never want to rock the pelvis. So you don't ever want to do this, because if there is like a fracture or anything going on, it can get worse because of that. So if you're pressing in on the pelvis and you feel a crunch, you stop. And do you guys use pelvic binders or do you use a sheet? You have the binders? Do you have pediatric ones? Okay. So what do you use for if you have a unstable pediatric pelvis? Absolutely. And that works just as well. I mean, I think a sheet works great as a pelvic binder as well, and I feel like you get like that big knot that you can actually like move the patient with it as well. So for the back, this is my fun fact of the day. So we as providers, we spent over 90% of our assessment on 50% of the body. We always do like the roll and turn and we look at the back, but we look at it like so briefly. So when we're looking at that, like what are we looking for? Especially when we're looking at the neck, when we're feeling down, what are we feeling for? Like a step off. Has anybody ever felt a step off? It's when you do, it's really scary. You feel it and you're like, whoa. And they've changed the protocol so often about when to put a collar on and when not to put a collar on. Like we backboarded everybody. When I first started, no matter what, everybody got, it was like Oprah, like you get a backboard, you get a backboard, you get a backboard. Like everybody was on them. And then they realized that these people were like getting like skin problems because they were laying on backboards too long. It didn't even do anything. And then people were in pain and having injuries from the backboards. But again, looking at the back, you don't want to miss anything, especially if you have penetrating trauma. So if you have like a gunshot wound in the front, you want to make sure that, is there a hole in the back as well? Is there significant bleeding? Do you have any step-offs? Do you have any step-offs going down the whole spine? And you want to look at the back of the legs as well. All right, so that's like the brief overview, and now we're just going to go through a few cases. Yes, ma'am. So for a step off, if you're like going down the back of somebody's spine and you're feeling this, you want to make sure that everything is in the same line. And a step off is if you feel like a little bone that's kind of out of place. So that's indicative of possibly a fracture or something that's torn that's pulled something out of place. Okay, so we're just going to go through a few case studies. This is like the really exciting interactive part. I know you guys are like real happy about that. Okay, so 4-year-old boy struck by a car going 25 miles an hour. That's what you got called for. And you are like real happy because you're like, yeah, I got this. I got this peds patient, 4-year-old got struck by a car, no big deal. No. Okay, so let's talk about kids and cars and go back to like physics, which is not my forte at all. So kinetic energy, it's the movement of an energy of an object. And so it's 1/2 mass times velocity squared. So let's do like a ton of math. So a car's going at 50 miles an hour is like, I don't know why I put 2,500, and then a car going at 70 miles an hour. So do you see just like getting hit by a car at 50 ends up with this number, and then a car going at 70 is almost double. So the speed of the car really does make a huge difference when kids are hit and when there's a collision. And the odds of being killed or severely injured in a crash doubles for every 10 miles traveled over 50 miles an hour. So I think about that, and I was driving here, and it was like the driving was pretty slow today because traffic was terrible. But when I've driven on the roads where like the speed limit's like 70, and I'm like, man, if I get into a car accident, I'm gonna die. This is terrible. Okay, so let's talk about kids that get hit by cars. So kids, when they get hit by cars, they're shorter, right? So their like center of gravity is lower, they're smaller, and they tend to go down and under. They're hit higher. So if like an adult gets hit, they normally will have like fractured legs and they go up and over the chair. Do you have a question? You okay? Oh, okay, I thought you waved. They'll go up and over the car and they get hit low. They end up with lower extremity fractures. But if a 4-year-old gets hit by a car, they go down and under, they're hit higher. Where are they normally hit? Chest, head, that's a lot worse. So if a guy gets hit by a car, okay, why are you running around the street? You got a couple broken legs, you're gonna be all right. But when a kid gets hit by a car, they're smaller than an adult, and they're getting all that impact on their chest and their head. So they most likely will have multi-system injuries. So doing that assessment piece, like that really good head to toe, looking at every single part and looking very deep into each system is very, very important. So kids, their chest, the wall is much thinner, and the bones aren't completely ossified. About like everything kind of like starts getting together after the age of 8. But the pediatric patient, especially the younger ones, their bones are like really squishy. Well, not squishy, they're like more like cartilage, so they bend a lot better. They always say that babies bounce. Well, kids bounce too. However, if you're hit by something really hard, the energy is absorbed. So the chances of having like a heart injury or a lung injury or more of an abdominal injury are much higher. Rib fractures and flail chests aren't very common in kids because the bones are so bendy. They haven't, like, not everything is completely stuck together and not everything's hard yet. Their diaphragm is higher. So what's the diaphragm? Right? It's like separating chest cavity, between abdominal cavity. When you breathe, it like moves up and down, all that good stuff. So in kids, it's higher, which means all of their organs are sitting up a little bit higher as well. And you can have serious injuries without like external signs. Because again, that area has a little bit more padding than just like, you know, your elbow. So if you fall and you bump your elbow, you get a bruise right away pretty much. But you can have serious injuries in this area and you won't see them externally. So that's why it's important to like press on the belly, because you might not see anything, and listen to the lung sounds, because you might not see any of those bruises yet. They're more at risk for pulmonary contusions, and that's not something that you're gonna see right away. Pulmonary contusions, they bloom over, like it's about like 20 to 32 hours after the injury. They can have a pneumothorax. So what's an open pneumothorax? Yeah, like, so there's like a gaping hole like in the chest. A tension pneumothorax? Closed and it's in there. So what's a sign of a tension pneumothorax? JVD, exactly. So having the jugular vein distension. What else? I'm sorry? Hypotension. How about absent lung sounds on one side? So when you're listening to the lungs and you don't hear anything on one side, what about their level of consciousness? Anybody with a tension pneumothorax, are they going to be acting normally? No. And why aren't they acting normally? Say that one, I just can't hear you. They have less oxygen, so they're hypoxic. So they could act belligerent, they could act drunk, kids could be like out of their mind. So, and as I do know that it's very difficult to listen to lung sounds in the middle of the road or in the back of the ambulance, that's one thing that you won't miss. I just told you the answer. So you can also have cardiac injury, because again, like a large force hitting a child's chest, it's gonna absorb that energy. Oh God, I keep on touching this microphone. And so if you have cardiac injury, you can get something called Beck's Triad. It doesn't matter what it's called, but what are the signs and symptoms of Beck's Triad? So that's just knowing that you have a problem with your heart. There's symptoms of cardiac tamponade. Did you already see the answers? So what's a sign? So hypotension, JVD, which we talked about earlier, and muffled heart sounds. I feel like everybody sounds like they have muffled heart sounds in the back of the ambulance, and it's not like, should I listen to my heart and then listen to their heart? Just remember that there are other signs, so looking at that neck. And if somebody truly does have JVD, you're not gonna have to look that hard to find it. Now, kids, and especially like 2 and under, do they even have necks? I mean, they are so little. It's like they have these gigantic watermelons sitting on this like body, and you're like, I can't even see your neck. So it is harder to see that in pediatric patients.
Can you walk us through that x-ray? I'm not 100% sure that we all can see that in a pre-hospital setting.
Oh.
What signs of tension?
Okay. All right, let me see if I can do this. Okay, so this is my quick non-radiology x-ray report for you guys. So anything black on an x-ray is air. Anything white is bone or fluid, possibly a foreign body. There's no foreign body on this. So right side or left side, where's the air? So I'm gonna just say this is the right, this is the left. So where's the air? On the left. So our lungs should never look like that. That means it's full of air, so nothing's able to expand at all. And it is starting to push over to the right. So what would we do for that? Oh goodness. I don't know who said what. Needle decompression, absolutely. What do we do in the hospital for it? Chest tube, absolutely. Anything else with that? Okay. Sorry? Oh yeah, the second, so you feel the clavicle, you go down to the second intercostal space, and then it's like right there. Or I think you can go like 5 to 6, like mid-axillary on the side. So we had talked earlier about like flexible bones. So the bones are still flexible. They haven't completely ossified yet. The muscles are underdeveloped. So all of the muscles, and I know that like this is like a very fun fact, everybody does have a 6-pack, even kids, but some of them are hidden a little bit in adults, and in kids they aren't as developed yet. So that that stuff that is protecting all of the organs inside, it can't protect it as well as an adult. And they are more vulnerable to growth plate fractures. So the parts that are still to ossify and get hard, those they're more vulnerable to break. Okay, so let's go back. We had a 4-year-old that got hit by a car going 25 miles an hour. So what are the potential injuries? Head injuries, chest injuries. Like, it could really be anything, because we don't know if this is like a tall 4-year-old, so we just know that when we get on scene, we want to do a full assessment. So we look at the head and the neck, no visible injuries. Look at the chest, no visible injuries, lung sounds were unequal, so that's like cluing us off that there could be a problem. So if you hear unequal lung sounds, the first thing I would do is like go back to like the neck area and see if anything else is going on, looking for any type of JVD, looking to make sure that the trachea is not deviated. The lung sounds are unequal. We know that this patient is unstable, or we just cannot hear with our stethoscope in the back of the ambulance. So you're looking at like the overall picture of the patient, you know, and I'm sure you have like lots of help in the back of the ambulance, so you can direct a lot of people to get vital signs and all of that for you. I'm just kidding. So if you do hear lung sounds that are unequal, you got to address it before you move on. Abdomen, no injuries you can see. Belly was soft and non-tender. Pelvis, no visible injuries. The pelvis was nice and stable. And there was obvious deformities to both upper extremities. So what you know and what you're going to tell whoever is going to be, like if you're going to be taking the patient to the hospital, if you're going to call a helicopter and have them. So how close is your closest hospital for you guys? Do you guys transport to Children's when you have pediatric patients?
Should go to Hopkins downtown.
Okay, so you guys go to Hopkins.
They can make it there, if not, we can take them aside.
Okay. And what's your criteria for flying a pediatric trauma patient? Okay. So in your report, you want to make sure, like what's the most important thing to say about this kid when you're giving report? Your lung sounds are unequal. Like that's like in your primary. That's part of your A, B, 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 B. Like my lung sounds are unequal. I don't know why. I can't see anything on the chest, but they're unequal. And then of course you want to get vital signs to correlate with this to see what else is going on. Do you guys put oxygen on all your trauma patients now? Right, so oxygen obviously would be helpful. All right, let's go to another one. Yes?
So what's the risk involved? Let's say I compress the chest
Well, if you decompress a chest that doesn't need to be decompressed, you can give them a pneumo, and then they'll take care of it when you get there. But if you've got an unconscious kid with no lung sounds on one side and you do it, I don't think anybody would blame you for it. And they'll take care of it when you get there. Okay, so 8-year-old boy, he was a backseat passenger in an MVC. You pull up and this is what you see. What would be your first question? Which car was he in? Absolutely. That would be I'd be like, oh, geez. Please tell me he was in the truck. Please tell me he was in the truck. He was in the truck. Okay, so what do we want to know? The first question, obviously, what car was he in? So we want to know the point of impact, intrusion, like if he was in the back seat, is there any intrusion on that side? Was he wearing a seatbelt? And how old did we say this kid was? 8? So is an 8-year-old going to be in a car seat or in a booster? These days he might be in a booster. They're changing the way we do car seats and boosters like all the time. And at an 8-year-old, if you've got a small 8-year-old, they could still be in a booster seat. You want to know if they're in the front seat, if they were in the back seat. If they were told that they were in the back seat and you find them in the front seat, is that concerning? Absolutely. And you want to know the speed of the vehicle. And again, just thinking about like knowing anytime that it's over 50 miles an hour, like the possibility of having an injury, a really bad one, is increased exponentially. And don't forget, kinetic energy, it's, mass times volume squared, so, Okay, so we're going to talk a little bit about the pediatric abdomen. So we talked about the chest and how the diaphragm's higher, but for peds, the abdomen is proportionately large, so it's pretty big. The head and the abdomen in a pediatric patient are the same size until they're about 2 years old. I totally did not believe this because I was like, that's ridiculous. But when I started working in the pediatric ICU, like one of the things you have to do whenever you get any patient in is you have to take like a gazillion measurements. And so I was a good nurse and I did all my measurements and I was like, ooh, I'm gonna find out if this is actually true. It is absolutely true. Kids' heads and bellies are about the same size until they're about 2. And then they get like that awkward, have you seen like little girls are about like 3 years old, they're in their first ballet classes and they're all sitting there with their big old bellies hanging out of their little tutus. Well, same thing happens with boys, but we don't see boys in tutus all that often. So their bellies are bigger. They have limited fat padding, and again, that musculature is a lot more weak, and the internal organs are sitting up higher, which puts them more at risk for having an injury to them. So the liver, the spleen, and the kidneys, they're more exposed. They're poorly protected. The ribs are softer, and because, you know, the ribs are going down a little bit, but even these ribs are softer, so they're just going to absorb the energy instead of rather like breaking with the energy. And they can go into shock very quickly without any visible signs of any signs of injury. So shock's bad, right? So what's the first sign of shock in a pediatric patient? We're not talking about adults here, we're talking about peds. Heart rate, absolutely. A heart rate's the first thing you notice. What's the latest sign of shock in a pediatric patient? I'm sorry? Blood pressure, so hypotension. What's hypotension defined in a pediatric patient? It's like 70 plus 2 times the age. So the one thing that I always think, I was like, okay, that's like quite a lot of math. But if I look at a kid and their blood pressure's under 70, I'm like, that's bad. So, and it's not like a really hard thing. So, and like the cutoff is about 8. So anything under 90 for an 8-year-old. And then you can kind of look at like where's it's going. But if you have a hypotensive pediatric patient, that is a late sign of shock. So one of the things that happen in shock, and we call this wonderful thing the trauma triad of death. Hold on. Oh, there we go. So one thing that trauma patients do when they bleed too much, and this can be internal bleeding that you can't even see yet, or external bleeding that you're like, oh my God, we gotta like contain this blood. Kids get cold, they get acidotic, and they get coagulopathic. So what are some of the things that we can do to stop these things? Well, first I'll go through what they are. Yeah. Oxygen, absolutely, and keep them warm. Keeping them warm is like the easiest thing to do to stop this cycle, because all of those 3 things kind of play off of each other. So how do we get acidotic? So poor perfusion to the tissues, and you get anemia from acute blood loss, so you don't have enough blood circulating in your body. You're hypotensive, so you're getting poor perfusion to the tissues out here because all the blood's being shunted to what 2 areas? The head and heart, right? The 2 most important areas. But then you can get acidotic because the blood's only going to right here and you don't have enough of it to go around. And then you have decreased cardiac output. You don't have enough fluid in the tank. We get coagulopathic because for dilutional coagulopathy. So what do we do for a hypotensive patient in the field? Fluid. So we give them fluid and then they're still hypotensive. What do we do then? We give them more fluid. They're still hypotensive. What do? We give them even more. It's like Oprah again. You get fluid, you get fluid. We give them so much fluid that we take what they had for blood and then we make it into Kool-Aid. So normal saline or LR, does that carry oxygen at all? No. What carries oxygen? Blood. So it's just like, obviously you don't have blood in the back of your ambulance, but it's just good to be mindful of how much fluid you're giving and making sure that that is transferred over in your report when you get to the hospital. So hypothermia, you get cold when you don't have enough blood, and you get cold if you have a traumatic brain injury. And why do we get cold if we have a traumatic brain injury? So if your brain's all jacked up, it's not telling the body how to regulate anything. You can get really hot, you can get really cold. And also intoxication, that can also cause you to get cold. So the things that you can do. So the first thing you said was great, like giving oxygen, put a blanket on them. Perfect. So if the bleeding is coming from an outside source, we want to stop the bleed. Is anybody taking stop the bleed? You know, the whole like, keep the blood inside the body by like packing or pressure or using the tourniquet? Okay. So if they are externally bleeding, stopping that bleeding, keeping them warm. So how do we keep patients warm in the back of the ambulance? A blanket, turn up the heat because we're already like, you know, a hypotensive patient that is going into shock because of massive blood amount loss. If you're in the back of the ambulance and even though the weather right now is really hot, they're still going to be cold. It's going to sound ridiculous to turn the heat on, but this is when you want to do it because you want to stop that vicious cycle. Because if that cycle keeps on going, they will die. Remember that we don't bleed normal saline, so just, of course, be mindful of your normal saline boluses, but if you're in the field and you're on your way to the hospital, you gotta do what you gotta do. And also maximize oxygenation. So for my ALS providers in here, what's another trick that you have that BLS providers don't have access to for traumatic injury with like shock or a lot of like multi-system trauma that will help you maximize oxygenation? I'm sorry? Okay, so there's that too, but I'm thinking more like pain control. So when you have a person that's in a lot of pain, they can get to tachypnic and their body's working a lot harder because they are in pain. Alleviating pain can also maximize your oxygenation. Okay, and then most of you guys said that you have already taken Stop the Bleed, but just to let you guys know, we do hold it at our hospital once a month. It's free, and we have nursing CNEs attached to it, and I feel like sometimes they count for Maryland for your hours, so we have it set up for an hour, and it's free and it's fun. And anytime that you want to attend anything at our hospital, that's free. So, and we're doing an EMS Pediatric Symposium in August. It's an 8-hour day, and we're going to have the hours done through Maryland. This is how you sign up for any type of education through us. Okay, so we had the 8-year-old that was in the back seat of the car, and he was restrained, and he was in the truck. So what could some of his injuries be? Absolutely, so maybe like a seatbelt sign that's like, so if he's 8 years old and he's in a seatbelt, do you think he was wearing like the shoulder harness thing? Probably not, he probably put it around his back, so you're concerned for his belly. He could have hit his head, I saw you doing that. What else? Absolutely, absolutely. Head injuries. So when you do your head to toe assessment, he had no visible injuries on his head or his neck, nothing on his chest. He did have a seatbelt sign to his abdomen. So what lives in the abdomen again? Liver, spleen, kidneys. So if you're seeing a seatbelt sign, what's that indicative of? So there's some blood loss somewhere. There is bruising. That would like perk my ears up and like make me, puts my index of suspicion of there is something going on with this kid. He does have this seatbelt sign. However, he doesn't have any visible injuries to any other part of his body. But if you wouldn't have looked under his shirt, would have you seen the seatbelt sign? That's why that primary survey is so important. Okay. 8-month-old that fell off the couch onto a carpeted floor. How many times have you, maybe this isn't too bad, like they fell off the couch. So the couch was 18 inches high, so pretty low couch, right? So you're like, oh God. So of course the parents meet you at the door. They have left the baby in the back because they are freaking out and they're like, the couch and it was this high and we got it from IKEA and we thought that we didn't have to strap it to the wall because it's a couch. And he cried immediately and then we put him down for a nap and he was totally fine. And then mom went in to find him in his crib and she found him with like noisy breathing and it was really hard to get him to wake up, which is weird because whenever they put their baby down, they want to eat as soon as they wake up from anything. So things about kids. So they have these giant watermelon heads. Again, they're the same size as their bellies until they're about 2. They're top heavy, so no matter what they're doing, whenever they fall, where do they hit? Their head. It's commonly the lead point in most falls and MVCs, so I really liked it when you said like looking at the head for that 8-year-old, because for me, I feel like every kid has an injury until it's been a head injury until it's been ruled out, because kids always fall, they always hit their heads, and the head seems to bleed like more than anywhere else, right? It always is like way more impressive because they're like all covered in, and you're like, okay, like where is it actually coming from? And kids fall head first. So when you hit your head and you fall, you have your primary injury. So you have that primary insult of falling and landing on your head. That's the first injury. But then we got to think about, our goal as providers is to prevent secondary injury. So we want to maintain a normal ICP. What do I mean when I say ICP? Thing that happens after you get whacked on the head. So we're going to go like a little deep with this lovely doctrine. So the skull's a rigid structure, right? Like we all have these things. There's only 3 things in the skull. So you have brain tissue, CSF, and blood. So Monro Kelley doctrine tells us, and it doesn't even have to be a doctrine, if you got a closed space and you got 3 things in it, if you have an increase in one, you got to have a decrease in the other, because there's nowhere else for it to go. So when you have one, and then right here, so what do you think this is? Well, so this is not normal. This is bad, and this is a collection of blood. So there isn't enough room for everything to go in, so something's going to have to go somewhere. So what happens when there isn't enough space and you start bleeding in your brain? Sometimes the brain tissue will go down the spine, so where it's herniation. So whenever you have increased intracranial pressure in your head, you're at risk for herniation. So quick signs of impending herniation, so you have a decreased LOC, and that makes sense, because if you get whacked in the head or you fall on your head and things are kind of jumbled up and like you got a big bleed going on and things aren't going well, your brain's not going to work right, so you're not going to be able to communicate with anybody or function. You can have unequal or non-reactive pupils. And then there's 3 things that are with Cushing's triad. So Cushing's triad, what are like 3 vital signs? What happens to your vital signs when you have a head injury and you have impending herniation? Say that one more time. Okay, so let's go a little bit easier than talking about pulse pressure, just like normal vital signs. Okay, so your heart rate goes down. What happens to your blood pressure? Goes up. What happens to your respirations? They're irregular, or they can completely stop. So what can we do for increased ICP in the field? Can we perform a neurosurgical procedure and get rid of the blood? No. I'm sorry? Okay, well, you do. You would also probably like to do regular things for the rest of your life and not go to jail, so there's that. Yeah. I'm sorry? Yes, so ensure oxygenation. You can put the head of the bed up at 30 degrees, so that'll, oh wow, the air turned off. Now I can really hear myself. The head of the bed up just a little bit. Low stimuli, so that's real easy to do in the back of an ambulance, right? You got all the flashing lights, which you still can see in the back sometimes, because I'm sure you're gonna have the brigade following you to the hospital. So you can try to dim the lights a little bit, but what's more important, dimming the lights or being able to really see your patient? Being able to really see your patient always trumps all, but just be mindful of that low stimuli, because the last thing you want to do is for your patient that has possible pending herniation to have a seizure, because that is really going to increase their metabolic demand. They're not going to be breathing adequately, so the low stimuli is a great thing, and you want to prevent seizures. Yes?
What's the difference between a shift and a herniation?
So a shift is when, so if you have so if you look right here, when you see the blood right there, see that line that's kind of going over on the side a little bit? That's a shift. So whenever we do a CAT scan and we see the blood, if the brain has shifted at all, that's what we call a shift. Herniation, which you can't really see on this view of the CAT scan, that's when the brain tissue is actually going down the spinal cord. So it's going through the foramen magnum. And once you hit that point, it's really not good. So that's why if you have a patient that is having a high pulse and a low blood pressure and not breathing that great, that is get them to another place right now. Do it, do it, do it. And if they need to be bagged, bag, because you want to do everything that you can to keep oxygen to that brain.
What point in newborns, what point do the fundamentals comes up?
Okay, so that's a really good question. So when we talk about like this 8-month-old, so kids have a little bit of a pop-off valve. That's what I like to think. So you got your anterior fontanelle and your posterior fontanelle. Which one closes first? Posterior fontanelle. So the posterior fontanelle closes at about 2 months. The anterior fontanelle, probably like 6 to 8 months. But that's a really good thing because kids have a little bit more room because their sutures aren't completely ossified yet, and they do have a little bit of a pop-off valve. So if you're like feeling the head of an 8-month-old and you feel a bulge here, is that a good thing or a bad thing? That's a bad thing because again, when we have like the rigid structure and if you got like something poking out of the top, you know that the pressure inside of that head right there is quite high. So things that we'll do, I don't think, do any of your medics, you don't carry either one of these, correct? So we carry them on the critical care transport team at Children's. We do carry these in our ambulance. So I'm like, who carries what? So a couple things that we can do that can decrease ICP pretty quickly that will give in an emergent situation before the child can get to the OR so they can do a craniotomy. And that's where they'll go in and they'll remove that blood. This will help, but only for a brief amount of time. So 8-month-old fell off a couch, 18 inches high. So what are we thinking? What are the things? Like, what can happen to an 8-month-old if they fall off the couch that's like 18 inches high? Well, not a lot, right? I mean, an 8-month-old that falls off, okay, so if like this is the floor, and they fall this high, I'd be like, why'd you call us? Like, what's going on? But a baby with snoring respirations or noisy breathing, that's more concerning to me. So I'd be like, well, in my head, I'd be like, do they have like bronchiolitis or were they sick before? Like, what's happening? Like, So when you're doing your assessment, because you're like great providers and you're not just gonna be like, oh, this isn't a big deal. You do this assessment and you see bruising on the head and the neck. You don't see anything going on in the chest. But in the belly, you see bruising in patterns, but the belly's not distended, but you're seeing like a pattern of bruising. For the pelvis, it's good and it's nice and stable. You didn't feel anything crunchy. There's no visible injury. And then the right lower one is really small. And then when you turn the baby over and look on the back, you see a lot of bruising on the back. So did this happen by falling off a couch? Yeah, probably not. So one fun fact, children rarely have significant head injuries or any injuries. Patient needs to go. So this is indicative of child abuse. This does not match the story at all whatsoever. What if your partner's like, oh, they could have gotten all of these bruises from falling off the couch, and they try to talk you out of making a report at the hospital? Do you care what your partner said? No. Like if you are concerned, like a salty dog that day and they've seen it all and done it all and did it twice and got this is a 12-year-old female, MBC, she was restrained. Where she was. So what are we concerned about? And this is a 12-year-old, so they're a little bit bigger. It's not as like, ugh. Abdominal injuries, possibly a head injury. I mean, multi-system trauma, right? You're like, okay, no matter. Head and neck, no injuries, you don't see anything? Yeah. Okay, so you don't see anything on the head or the neck. Are nice and clear. Abdomen, no injuries are noted. Pelvis. Make sure he's no injuries. She is alert and oriented. She remembers the whole accident, and she tells you that she can't feel. So again, your findings, you had lack to the inside of the left leg, so in the groin area. Even though so she can move it, she can move them, and she's tachycardic and hypotensive. It's really good to paint that whole picture. And a lot of the times, the physicians on the end of the line or the people listening, most of them have not seen what you see every day. They don't know what an extrication of 10 minutes is. So things to add in, well, first, tachycardic and hypotensive. And that it took over 10 minutes to cut her out of a car. And significant intrusion. Yeah. Oh, I thought you were going to say something. Yeah. So, and if you say the word significant, that's good enough for them most of the time. And I've had a lot of conversations with our docs that answer the phones, and I'm like, if somebody says significant, that's significant. Nobody's out there with a tape measure and saying this is exactly 12 to 18 inches. That's just not going to happen. If it took 10 minutes for somebody to cut somebody out of a car, the intrusion was significant. So would you, does that report really show what's going on with this patient? Yeah. Okay, so are you interested to find out what was really going on with her? So I actually have pictures. I'm excited about that. She had a right femur fracture, and she had an unstable open book pelvic fracture with bilateral acetabular fractures and a sacral fracture. She had a 12 centimeter full thickness lack of the left groin. So what happened with this kid? Everybody got distracted by a 6-inch lack to her groin and never really saw anything else. And when they did that, when they did their assessment of the groin area, they really never pressed on the hips, because if they would have, guess what would have happened? Yeah, she probably would have screamed out in pain. And she didn't walk to the ambulance. So as soon as she comes into children's, everything is happening, and they get a CT and an x-ray of her pelvis, and they're, and that's why she was bleeding into her pelvis. Can you bleed a lot into your pelvis? Absolutely. So if you see a lack in the pelvis, it doesn't mean that there's just a lack. It could be a fracture underneath. That's another thing with kids. When you see a lack, the last thing you want to do is touch that area, but don't be afraid to, because you don't want to miss any big injuries. Now, of course, she got to the hospital very quickly and she was diagnosed appropriately, but it's just things to think about. It's not always what meets the eye, because if you just see that lack, you're like, how how'd she get a laceration to her groin in a car? Well, she got it because she had an unstable open pelvis fracture. Has anybody seen an open hip fracture? This was the first one I ever saw. Okay, so normal, this is also my non-radiologic quick thing. So here's your ilium, your joints, sacral sinuses, your sacrum that's going down. And you really want this area to form like this nice perfect ring. This is a normal pelvis x-ray. This is what hers looked like, right? But the only visible injury was a lac on the inside of her groin. Yeah, yep. So it's like when they say open book, that means nothing is together. So if you look at like, see those pieces are supposed to be together? Like, not at all. And then we have, you know, the cracks here and here and here. That's her femur fracture. So a lot of the times, like, kids aren't really great about compensating for pain at all. They'll be like, this hurts, this hurts, this hurts, this hurts. Kids are not great at telling you exactly where the pain is. They're scared. And she was getting hypotensive, so she might have not been thinking in her best way, right? She was tachypnic, so she was breathing fast. She had a high heart rate, and was in a really bad car accident. Sometimes all of that adrenaline, I mean, not only just with adults, but even more so in kids, they aren't gonna feel the same pain the way that adults would. Here's another picture of her femur fracture, and you can see more of the pelvis fracture with that. Absolutely. So that's one of the tricks that one of our ER physicians actually was teaching our surgical residents like 2 weeks ago. So when you are looking at and doing an assessment for a pediatric patient, one of the best ways to do it, and this is also really helpful for any type of like special needs kids, because they really can't tell you what's going on, let alone a normal pediatric patient. But if you take your hands and run them down the extremities so you can actually feel the bones that you're going down, on the legs, that will tell you more so than not if there is a deformity or if there is a fracture or anything that is abnormal going on. So taking your hands and trying to go around as circumferential as you can and going down each of the long bones in the body. Not in kids, not really, not really. And oh yeah, absolutely. Yeah, it's not as obvious in kids. Okay, I think this is the last one. How we doing? Everybody still doing okay? We good with one more? Okay, this was a call that was run, maybe about 2 years ago. So the call was for a 2-year-old in an MVC, but the patient had scald burns to 90% of his body, and he was unresponsive. And you're like, how did that happen? So what questions do you want to ask? Like what's going through your head? Other than, why am I on this call? Because this would be like, why am I going on this call? Like, how do we have a 90% burn to a child in an MVC and they're unresponsive? Absolutely. What happened before the crash? Is the car on fire? That's what I'd want to know. How'd they get a burn? Is the car on fire? The car was not on fire. So the car actually ran into a bus, and the child was found on the floorboard. So injuries based on this mechanism. You have no idea. You're like, this does not make any sense. Like, why is there a 2-year-old on the floorboard of a car? Why'd the car run into a bus? There's no adults anywhere because the driver fled the scene. Was there only one other person in the car? You don't know. You don't know anything. You just find a 2-year-old on the floorboard of a car. So the only thing you can do here, because you have no story at all, is your assessment. And we know that he's also unconscious, which is like, why? Okay, so when you're doing your assessment, you have partial thickness burns everywhere. So partial thickness burns to the face and the neck, and there's a sparing pattern on the head. There's partial thickness burns to the chest, abdomen, pelvis, with skin sparing on the pelvis and the extremities, and there's burns to the back. What else do you want to know? And he's unconscious. You don't know. What else do you want me to give you that you want in your assessment? Okay. Absolutely. But you don't know. You just see that they're partial thickness burns. There's no leak or anything in the car. There wasn't like hot coffee next to where the kid was found.
That car went under that bus.
It did.
That exhaust from that bus, it was all.
Nope.
Was the driver's
Nope.
What about the airbags?
What about abuse before?
Okay, that's a good question.
Really trying to get the kid to the hospital.
But you don't know any of this because there's no parent. Any part of your other assessment that you want to know? Okay, no, nothing. You don't feel anything. The only thing that you see is this.
Where was this kid found?
Right on, like in the front seat floorboard. Passenger side. And no adults.
Airbags?
Only on the adult side. Nothing.
And these are fresh burns?
They look fresh. They're open. Okay, okay. Is there anything of your assessment of the patient that you want?
Was there like a hot cup of coffee or
Nope, no coffee in the car at all.
airway?
They're breathing adequately, but unconscious. Nothing in the airway, but unconscious. For the primary survey, when the child got to Children's, when they did the first thing we do, like for A, B, C, D, E. So airway was intact, but the kid was breathing adequately-ish. Circulation was okay. The blood pressure was fine. But when they were doing their neuro assessment, so this is an unconscious kid with like burns. So partial thickness burns, are they painful or not painful? Are they the most painful or are they the least painful? They're the most painful. So like a superficial burn, it's a sunburn. Who cares? Full thickness burn, not normally as painful because you kill all those nerve endings. Partial thickness burns are the most painful because that's where the nerve endings are exposed. So should you ever have a patient who has that much of a burned area that is unconscious? No. So checking pupils in kids I know is like not easy, but an unconscious kid, it's actually a lot easier because you can just pry those eyes open. So we pried the eyes open in the code room and we looked and the pupils were unequal. Unequal pupils, what's that indicative of? Head injury. Now, did he get the head injury because of the car accident? Or did he have a head injury when he was in the car before they got into the accident? And then a sparing pattern. So when I say sparing pattern, what do I mean? So if you think about like a whole arm that was burned, and then if you like open up the arm and like right in the crevice right here, there's no burn at all, that's sparing that skin. So if a child has been held under water that is too hot, the body's first instinct is to do this. So if you have a burn, you won't have burns in the creases. And that's what I mean when I say sparing pattern. Like parts of the flesh were spared on both arms and both legs. And there was a little bit of a sparing pattern on the head as well. So you guys want to know what happened with this kid? So they found out later. So the mom was at a housing meeting and she left her 2-year-old in the care of her boyfriend, put the child in really hot water so they couldn't see the bruising. And that often happens with child abuse because if you burn off all the skin, you can't necessarily see the bruising as well. And he had a massive head injury because of being beaten so much. So he then called mom, who was at the housing meeting, and said, so-and-so fell into the bathtub. I need you to come home right now. She came home and was like, what happened? So she got in the car with boyfriend who was holding the child and was driving along and then hit a parked bus, and then everybody fled the scene. And that's what they found. But the key to remember in this is a 90% burn is a distracting injury. When you see 90% burns on anybody, especially a child, especially a 2-year-old, when they're in a car and you're like, how did you get burned? Like, the car's not on fire. There isn't a hot liquid in here. There's no way that anything that hot could have got on this kid. You don't want to forget your ABC. So like that primary survey, the airway, breathing, circulation, that disability, looking at those pupils, and a kid with a 90% partial thickness burn should not be unconscious at all. Looking at those pupils, that would have told our providers like right off the bat, this is a problem. Now, of course, the child like got to the hospital very quickly anyway, but it's one of those things that don't forget like the basics when you see something really distracting, and just don't get distracted by distracting injuries. Just like in the laceration to the groin, that was really distracting, because also like exposing a 12-year-old girl, especially if you are an all-male medic crew or an all-male BLS crew, that is like awkward for everybody, but you still have to, like, you don't want to get distracted and be like all weird when you make sure that you're looking at everything and not get distracted by stuff like that. And if you guys don't have any questions, thank you so much for your time and your attention. All right. Providers to interact with EMS, because I think it just gives like a better understanding of like what it's like out there, what it's like inside the hospital, so we can like work better as a team. And I think our nurses are like so over me, because I'm like, will you just stop and think about what you're saying? Like, come on. But I guess that's why they have me like working with our nurses to understand EMS just a little bit more, because I'm like, y'all need to just quit, just stop it. So. All right, and we are having that symposium, and we had our first one last year, and everybody seemed like really happy about it. We did like pediatric airway management, and we did like the tricks of the trade for pediatric IV. And even if like some of these skills were like for ALS providers, we were like more than welcoming to have any of the BLS providers participate in that and learn it, because even if you can't do it in the field, if you're with somebody who and assisting somebody who is doing an advanced procedure, if you have been trained how to do it, you know what to hand them a lot easier, and everybody seemed to like really enjoy that as well.
Saturday, August 10th?
I think it's the 8th.
Saturday, August 10th?
Is the 10th? Okay, yes, that is the 10th.
Saturday, August 10th. These guys, we're going to be able to live stream that. So Ashley and I are going to go down and we're going to live stream the lectures at the hands-on. So definitely benefit of being there in person, but if you can't make it in person, we'll send out emails to the live stream.
Yeah, and the hands-on stuff is like what people really enjoyed last year. And we tried to kind of like split it, so we got like 4 hours of didactic and like 4 hours of hands-on, because, I mean, who wants to sit in a room for 4 hours? I certainly don't, but because of, like, we tried to do like a good split, so there wouldn't be so it'd just be easier for people. And the focus this year is going to be on preparing for MCI events. And we have a really cool speaker her name's Dr. Joelle Simpson. And what we call her is our master of disaster at Children's National, because she is the one that is like all about like MCIs and like getting our hospital ready and how we're working like within the system if there ever is a terrible event in our area. And she's like really cool and she's a good speaker. And she has like the coolest title. I want to be the master of disaster, but she already is, so I can't be that. All right.
We've had 3 PEDS topics in the last 6 months with this EMS series, and all of them came from Sydney, so thank you.
Oh, cool. All right. Well, thank you guys. Have a great night.